we're going to actually be introduced very shortly to Dr. Tsagkaris, Dr. Stavros Tsagkaris. I believe you actually come from Athens originally, Dr. Tsagkaris. I've actually just arrived back from Athens about 2 days ago. Yeah, literally flew in from Athens a couple of days ago. So Dr. Tsagkaris is from the Evelina London Children's Hospital in London. You are a senior pediatrics trainee in London, I believe. I'm an aspiring pediatric neurologist. You won, I understand, in June of this year, Dystonia Europe presented to you the Dr. David Marsden Award. And that was June this year. And I think this presentation is going to cover your paper that led to that award, I think, isn't it?
Yes, that's right. Yeah.
The title of the paper is Metabolic Patterns in, I'm going to read this out, but in brain, fluorodeoxyglucose PET relate to, how do they relate to etiology in pediatric dystonia? And if I can, and do let me know if I'm actually misrepresenting this, if I paraphrase it in layman's terms, it's an understanding a little bit more of some of the causes of pediatric dystonia using something called positive emission tomography, which is a kind of procedure to understand the etiology, the causes of some types of pediatric dystonia. But please let me know if I've paraphrased that.
Yeah, no, exactly that.
Really, just to actually translate that into layman's terms. So with that, we'll look forward to hearing about your latest paper.
Thank you very much. So good morning from me as well, and thank you very much for inviting me here today. It's a great opportunity to speak today, and then also to have received the David Marsden Award. Dystonia. So can you see my slides?
Yes, we can.
Yeah. So Dystonia Europe and the David Marsden Award, in particular, over almost 2 decades now, have been stimulating research in the field of dystonia and increasing visibility for patients and their families. So for me, and speaking on behalf of my whole team at Evelina, it's a great honor and a great recognition of our work there. So today, as you mentioned, I would like to present to you the results of my ongoing research work at Evelina, which focuses on brain imaging patterns in children with different kinds of dystonia. Yeah? So I'm aware maybe a large part of the audience is more familiar with adult onset dystonia, but I strongly believe that those findings will be of benefit both for the adult as well as the pediatric population. And this is because, as you mentioned, they offer further insights into the pathophysiology, so the mechanism that lead to dystonia, but also because, as we know, the majority of children with dystonia will eventually become adults with dystonia as well. So pediatric dystonia is often under-recognized, difficult to diagnose and classify, and exerts a profound impact on children and their development. However, current pharmacological as well as surgical interventions often do not fully meet the patient's needs. So it's imperative to have a better understanding of dystonia's pathophysiology. But what do we mean by pathophysiology? Well, this is the biological mechanisms that lead to the development of the signs and symptoms of dystonia as we know. Okay, so when we think of dystonia, we think of a neurological condition which, as the classical definition says, it leads to abnormal movements and postures, which are mediated by the muscles. So when we think of where those biological mechanisms are that lead to the development of the symptoms, we think of the whole pathway from the brain down to the, let's say, the final nerve before the muscles. Yeah. So in order to try to find the reasons for the disease, we first, what we very frequently do is try to check the structure of the brain. And we most commonly do this using MRI, which is this imaging modality here. And what we mean by structure is, is there something extra there that shouldn't be there, something missing, something malformed or injured. And here on the left, you can see an example of a normal brain MRI. But here on the right, where the arrows point, you can see some brain injuries in basal ganglia as well as thalami, which are areas known to be associated with dystonia. So to look for the problems with the structure of the brain, we use MRIs. But we're also interested in the integrity of the pathways that lead from the brain to the periphery, as well as the opposite direction, from the periphery to the brain. And in order to assess, though, a couple of tests that we frequently use at Evelina are the central motor conduction times, which are neurophysiological tests that assess the integrity of the pathway from the brain to the periphery, and the somatosensory evoked potentials, as we call them, which are, again, neurophysiological tests which assess the opposite direction. And what we do is we send a signal from one end and try to measure how quickly it reaches the other end. And any delayed or any absent response would indicate a problem in the integrity of those pathways. Okay. So why are those neurophysiological tests important? Well, here you can see the results of a research work by my colleague Verity McClellan and her team back in 2018, where it shows that in all those different etiologies of pediatric dystonia, a proportion of those children had either one or both of those tests abnormal. And quite interestingly, you can see that this gray column here, which represents the sensory test, the one that comes from the periphery to the brain, is more commonly abnormal, as indicated here in the abstract. Approximately half of the children will have that abnormal compared to 1/5 of the children for the motor test. I think that's interesting because we classically think of dystonia as a motor disorder, and we could possibly expect to find the problems in the tract that goes from the brain to the periphery. But actually how we interpret the information we receive from our environment and how we process this seems to play an even more important role in the disease. Also, those neurophysiological tests are important because from the same paper, we learned that patients that have one or both of those tests abnormal are less likely to or have more limited beneficial effects of the brain stimulation later on. Okay. So what we do at Evelina when a child comes in with dystonia as a predominant movement disorder and is assessed for eligibility for deep brain stimulation is, of course, they will have a detailed clinical assessment by the medical professionals, but also by a large team of multidisciplinary team, including therapists, as you can see, occupational therapists, physiotherapists, speech and language therapists, as well as nurse specialists and clinical psychologists. And then we go ahead with some of the investigations. And we already mentioned that we will look for problems in the structure of the brain with the MRI, in the integrity of the pathways with the neurophysiological tests. But since the beginning of our service, we would also do a PET scan. And this is the positron emission tomography scan that you mentioned in the beginning, in the introduction. And why we do that? We do that because we would also like to assess the function of the brain. The modalities I mentioned earlier, brain MRI and neurophysiological tests, look more for structural problems. But what we thought is that we would also like to know how the brain functions or how different brain areas actually function. And so what the PET scan does is before the scan, we inject the patient with, let's say, glucose analog. And we say a glucose analog because brain cells normally use glucose to function. And this analog will have a radioactive tracer. So it would show up on the scanner later on, and we would be able to say where it accumulated more, from which areas of the brain it was used more or used less than we would expect. And we say that the areas that use it more are more active, function more. The areas that use it less are less active, function less. And we thought that this would be important because from what you can see in this graph here, we know that there's a large proportion of patients that have normal other tests, like normal MRI, normal brain structure, normal neurophysiological tests, but who would have dystonia, who would have a varying degree of severity of dystonia, and who would also benefit in a different way from DBS, some more, some less. And we thought that apart from those patients have a brain that looks completely normal, but is it functioning as we would expect as well, or some areas functioning in a different way that we would expect? And that's why we decided to look at the PET scans of those patients. So, and also we noticed that the reports in the medical literature about functional imaging in children were quite limited. So functional MRIs, which is another imaging modality, were limited to only some focal or mild dystonias. and pets were mainly limited to adults. So we decided to take advantage of PET's increased resolution and sensitivity as an imaging modality, and also of the fact that it truly would represent the function of those areas. And what this particular project focused on was retrospective anonymized cohort study. So we retrospectively collected imaging as well as clinical data from patients that visited our service between 2007 and 2018. With a mean age at the time of scan for our children being 10.5 years. Now, this is the imaging protocol, and it's the reason it is important is because, first of all, there was a 3-hour fast for our children, and then there was a 30-minute uptake of this glucose analog that I mentioned. This was the time of the injection and the time left for the analog to be absorbed by the brain cells. And then the patient would undergo general anesthesia and the actual PET scan of 15-minute duration. So we needed the general anesthesia so that the patient is able to not move whilst having the scan, which is important, especially in children with dystonia. Some of them have very severe forms of dystonia. It would be very difficult for them to stand still for the entire 15-minute duration. But dystonia will be abolished with sleep. So it's important that we injected the glucose earlier on. And so what we see in the scan is actually the awake, resting state of dystonia. What we also needed was what we call healthy controls. And that is because, okay, in the PET scan, we can see, let's say, increased glucose uptake, so increased activity of a specific area of the brain, or the opposite, decreased activity. And we know that this is increased or decreased compared to the rest of the brain of the same patient. But is it increased or decreased compared to let's say, an individual without dystonia? And in order to have that information, we had to compare our groups of patients with the scans of people without dystonia. And so we had 39 healthy adult PET scans kindly provided to us by the University of Marseille. And we used an imaging software called SPM12 for our analysis. So here you can see the age distribution of the patient group, the dystonia group, and here the age distribution of the control group. And here is the etiologic distribution of our patients. So you can see that we have in total 10 different etiologies, 7 of them belonging more to what we call like genetic inherited dystonias, and the rest being acquired dystonias, predominantly cerebral palsy cases. And you can see that the cerebral palsy ones are the main bulk of our cohort, but for the genetic ones, given especially the rarity of the condition, I think we had significant numbers for each one of them. And so after a procedure that's called quality control, where we eliminate scans that have some technical issues that would mess with our results, we ended up with 144 patients with scans suitable for analysis. So before moving on to the results, and those might be a little bit more scientific, I would like to explain to you how to interpret them and what you'll see in them. So all results are displayed in either one of 2 templates, so either a normal MRI, I'll show it to you later, or something called Hammer's Atlas, which is a 97 region brain atlas developed by one of my research supervisors called Alexander Hammers, and it helps us locate the results we see better. You will see some blue blobs, so some blue areas, which are areas of relative regional hypometabolism. So what that means is areas where they have less glucose uptake in the disease group compared to the controls. And you'll see some yellow, red areas which indicate hypermetabolism, so the opposite, increased glucose uptake in the dystonia group compared to the controls. Brighter tones of each color indicate higher statistical significance, meaning a stronger result, let's say. Yeah. So we start with our first group, and this is our DYT1 patients. We have 7 in total. This is a group that classically responds well to deep brain stimulation, to the extent that now we kind of skip some of the investigations like the PET scans when we know a patient has DYT1, and in cases that the family and the patient agrees, maybe move on straight to DBS. But we had 7 patients with this PET scan available, and when comparing their images to the healthy controls, we found that there was relative hypometabolism, meaning less glucose uptake, in the posterior putamen, which is this area of the basal ganglia here, in the dystonia group compared to the controls. That's interesting because their MRIs were actually normal, so structurally, or for most of them, which means that structurally the brains look normal, but when you look at them from a function standpoint, you can see some changes. And this is an example of dystonia-relevant regions, meaning we know that dystonia will be classically associated with the basal ganglia. We have a finding in the basal ganglia here, but you'll see later on in my results that for some other groups, we had some quite unexpected findings. Second group is patients with DYT6 dystonia. We had 3 patients in this group, and you can see that now the results for this group were again hypometabolism, so less glucose uptake, but not only the posterior putamen, they also extended in the posterior globus pallidus, which is the area where we would usually insert the microelectrodes of the leads of the DBS. Again, an example of dystonia-relevant regions. Now move on to DYT11, the dystonia myoclonus group. We had 6 patients in this group, and here you can see some interesting findings. So the same 2 areas as before were involved, meaning the globus pallidus and the putamen, but this time only their anterior aspects. And we think that this, and as you can read in the paper if you're interested as well, we speculate that this represents a correspondence between the imaging findings and the clinical findings of those patients, because a large number of patients with DYT11 will have symptoms like an obsessive compulsive disorder or anxiety, which are called like limbic symptoms. And those are the areas of those 2 brain structures that are known to be related with such symptoms. So we think that the imaging findings match what we see clinically. Also, we saw some hypometabolism, so less active areas in the frontal cortex. And this is an example of findings replicating the existing medical literature, as there is this paper by Cabernet in 2013, where using functional MRI, they found similar, at least, findings in the frontal cortex of their patients. Now, another group is a KMT2B group, quite a rare condition with 7 patients in this group. And you can see that we had some bit more extended findings in the posterior globus pallidus, putamen, and head of the caudate, and temporal lobe, all being hypometabolic. Some of them, like the temporal lobe ones, could be related again to their clinical symptoms like the sensory neurohearing loss or whispering dysphonia dysarthria that some of those patients have. So here are the findings again. And then we move to another condition, Lesch-Nyhan disease group, which is a group with quite severe dystonia at baseline and some self-mutilating, self-harming behavior frequently. A group that interestingly has normal or almost normal MRIs, but in the case of the functional PET imaging, we had quite striking findings of pretty much global hypometabolism, globally reduced glucose absorption, including both areas of the cortex of the brain, as well as the basal ganglia. Then we move to another group, which is a glutamic aciduria type 1 group. Again, a group with quite severe dystonia at baseline, a group where now we actually most frequently check it in the Guthrie card, in the Newborn screening of the patients. Well, we had 9 patients in this group, and you can see very significant, indicated by the high T-score, very significant hypometabolism in the putamen and the globus pallidus bilaterally. But in comparison to previous groups, those patients indeed have findings in the MRI in the same areas as well. So I believe that part of the degree of the hypometabolism we see is because of the brain injury they suffer in the same areas and the ensuing, for example, atrophy. So here and here are the findings. And I'll move on to the first group with hypermetabolic findings. This is the PICAN group, which stands for pantothenate kinase associated neurodegeneration. So a group that has iron accumulation in some areas of the brain. And here we have hypermetabolic findings. So increased glucose uptake in the parietal lobe, in the upper parts of the parietal lobe bilaterally, and reduced glucose uptake in the cerebellum as well as in a couple of other areas that are not illustrated here. I would need more slices to do that, but it's in the insula and the frontal cortex. And interestingly, not in the areas where we usually see findings in the MRI, which are the basal ganglia. And as we hypothesize in the paper as well, what we interestingly see in those patients when they have deep brain stimulation and when we get some recordings from the leads inside the brain, we see that they have what we call regular firing patterns. So that's another indication that the basal ganglia might be functionally okay, despite the structural abnormalities, but other areas of the brain contributing to the clinical picture as well. Then we move on to the acquired cases. And first of all, we have the cerebral palsy caused by kernicterus, so very high jaundice levels as a newborn. Here you can see quite extensive findings of hypometabolism, so less glucose uptake in several areas of the brain, so the globus pallidus, cerebellum, brainstem, temporal cortex, and insula, and the same and similar increased metabolism findings in the parietal lobe as before. Quite similarly for the next group, which is the preterm group, we can see extensive findings that include several areas of the brain, quite similar to the kernicterus one earlier on, and the same hypermetabolic findings in the superior parietal lobe. And so here and here. And then lastly, we have the cerebral palsy term cases. So those are cases caused by hypoxic ischemic encephalopathy at term, so full-term babies. And here you can see more constrained findings on the posterior putamen and globus pallidus, as well as slightly extended to the thalami bilaterally in terms of hypometabolism, so less glucose uptake, and more extensive hypermetabolic findings in the superior parietal lobe again, but also in areas of the frontal lobe like the precentral gyrus that are known to be associated with movement. So I know I've said quite a lot of things in the results, maybe a bit confusing things as well. I try to summarize all those here in this table. But essentially, the take-home message is that for across all those different 10 etiologies of dystonia, there are some commonalities as well as some signature characteristics for different groups. So commonality similarities are, for example, the hypometabolic involvement of the globus pallidus and the putamen, two areas that are classically associated with dystonia in almost all of the groups. So we speculate that this could represent inherent characteristics of the dystonia as a condition in general. However, different groups had some distinct signature characteristics. So, for example, the isolated putaminal involvement in DYT1, which could be related with a more favorable prognosis for those patients. The anterior involvement of the lentiform nuclei in DYT11 that we spoke about, the limping association earlier. The global hypometabolism in Sneihan disease, as well as the isolated finding of frontal lobe hypermetabolism in the cerebral palsy term group. So, so this is one of the take-home messages. Something I would like to comment on is what is difficult for us to say, especially for some of those groups, is whether the results we see are the results of the condition itself or of some years of compensation because of having the condition. So, for example, especially for groups that present very early on with dystonia, like the cerebral palsy cases, and who would have the scan much later on, like 2-3 years afterwards when they are assessed for eligibility for DBS. It's difficult to say if some of the findings we see here, like for example, this hypermetabolism, is what they will have from the beginning or a compensatory change in the function of some brain areas because of living with dystonia for a few years. We would need more information in order to be able to confidently say this. Now, we believe that this research work also illustrates is that dystonia is a network condition, and it supports the network model for the dystonia. What that means is that in the past, we thought of a dystonia as a disease of the basal ganglia, as I mentioned. But now, accumulating evidence shows that several areas of the brain are involved in a network way. So, for example, we saw earlier that some of the diseases have, some of the etiologies for dystonia had cerebral hypometabolism, so less uptake in the cerebellum. And in this graph that we propose in terms of how the different brain areas relate to each other, we consider the cerebellum as an off switch to the thalamus normally. The thalamus being the last port before movement, let's say, which could contribute to more movement. So if you have hypometabolism in the cerebellum, we can think of it as less inhibition of the thalamus. Less inhibition pretty much means more activation, so more movement. And this is an example of how the connection between different brain structures, as supported by this study as well, could lead to the development of dystonic symptoms. Now, how could this translate into clinical medicine? Well, first of all, I strongly believe that having better understanding of the pathophysiology of the mechanism of the disease will inevitably lead to advancements in its management, therapeutic options, therapeutic targets. So, for example, and again, that's maybe like a long shot, but something to think of, is speaking about the cerebellum earlier on. If future studies replicate our results and we see a consistent involvement of this area in some of the dystonia etiologies, we could think about whether, for example, in the future, the cerebellum could represent a target for the brain stimulation, something that's already tried in some basic science models. So that's one way to think about it. Another way is providing deeper phenotype, which means that for different etiologies of dystonia, having their clinical signature characteristics, imaging signature characteristics, neurophysiological signature characteristics. And therefore, this will help prognosticate better and provide a more individualized patient care. Why? Because, for example, we could say to our patients that, with your condition, with this particular subcategory of dystonia, and with the imaging and neurophysiological findings that you are more or less likely to benefit from a specific medication or from a specific intervention, like, for example, the brain stimulation. I think that will have a very positive impact in individualizing patient care and working towards what we call like precision medicine. And also, and especially in children, we have a lot of patients that have dystonia, maybe have normal MRIs, and their genetic testing so far hasn't indicated a specific genetic etiology. And we call those children, those cases, like idiopathic cases. But what we could potentially do is, if we know that a patient doesn't have a specific genetic diagnosis, but all their other characteristics, clinical imaging, neurophysiology, are similar to a known genetic etiology, this could again help prognosticate, give them a better prognosis and better picture about what they could expect, because we would possibly expect them to progress the same way the known subcategory of dystonia would. So we strongly believe that this research work adds a missing piece to the dystonia jigsaw. So, and what about future research possibilities? So where do we plan to take it from here and build on the existing results and work? Well, first of all, we now, and especially over the past 5 years, have a lot more new genetic conditions and groups that we used to have 1 or 2 patients in some of our subgroups. Now have more patients, so we're planning to expand our work to include those different etiologies. We plan to incorporate neurophysiological data and see how this relates to the PET findings we have. And actually, this is something that we've already done and submitted for publications. Hopefully, it will be published soon. To incorporate surgical data, so microelectrode recordings from the DBS, and see how those could relate to the functional details we find from the PET studies. Something, another big goal, and I would say my main goal would be to see the possible role of PET scans in predicting outcome of the DBS. meaning trying to see whether having particular findings in functional imaging could indicate whether someone is more likely to benefit a lot or less from DBS. Like we said, for example, for MRIs, that if you have significant injuries in MRIs, it might make you less likely to benefit from DBS, or the same for the neurophysiological testing. And then another goal that we're thinking of would be to, for some of the conditions, consider follow-up PET scans like after DBS to see how such a procedure has affected the function of the brain and the function of specific brain areas. There are also some artificial intelligence related opportunities, but I won't get into more details about that. So I would like to say a very big thank you to the whole complex motor disorder service team at the Evelina London Children's Hospital for their amazing work over the years. It's a great team that I've had the pleasure of working with. And particularly a very big thank you to Dr. Jean-Pierre here on the left, who has been my research supervisor over the years and has provided me with invaluable support and guidance throughout. Thank you very, very much for your attention, and I'm looking forward to any questions you might have.
Hi, Dr. Tsagkaris. Thank you so much for that. A really complex area, but we do have some questions coming in. I know this person myself, they have a background in engineering, so they have a specific interest in some of your work. So her question is, as an engineer, she used to use something called a time domain reflectometer to treat problems in electrical cables. Is that a similar method that you use to check neural pathways?
Not that I'm aware of. So do you mean about when we do the DBS or?
Yes. Yeah.
No, not that I'm aware of, no.
Okay. Okay. And the other question is, does the in terms of the metabolic profile, does the lesser uptake of glucose cause the lower metabolism? So is that what is driving down the metabolism?
Oh yeah, I mean, I use those two terms interchangeably, but they're the same thing. So we mean metabolism of the glucose, yeah?
Yeah.
So less glucose uptake, less metabolism of the glucose in those brain areas. It's the same thing, yeah.
Okay. Okay. And a question about application to clinical practice. So I think that you summarized by actually saying that this could actually lead to, I guess, more personalized medicine, couldn't it? A more personalized approach for patients. On an actual anatomical level, could this actually be applied that you have a different way of placing the electrodes within the brain? So within DBS, could this research actually inform that anatomically as well as on a case-by-case patient basis?
Yeah, well, I hinted on that. I think that this would be, we can't confidently say this now. We would need a lot more research to be done in the field, and a lot of some of our results being replicated by other studies, and then thinking about neurosurgical, from a neurosurgical point of view, if other targets would be feasible targets or not. So classically, we target the globus pallidus. In some cases, they could be the thalami. In some cases where the globus pallidus is severely injured, in 2 cases in our cohort of patients, we have used subthalamic nucleus. Yeah. And other areas, like as I mentioned in the discussion about, for example, cerebellum, are tried. And I know, for example, from a recent conference that I attended, that they're tried in mouse models, and we're trying to establish a connection between other brain areas and the basal ganglia. Those are tried at the basic science level, but to be translated into pediatric or adult patient care, I think we need more work to be done on the field. Yeah.
Okay.
It is something to think of, though. Yeah.
Okay. And final question before we close is, you're suggesting neuroplasticity. So are you, and which we now are aware of, are you concerned that the brain areas change with maturity. So actually that as the disease progression and as the person ages, that actually the brain will actually change in some way in that passing between the time of the images.
Well, yeah, I think it depends on the condition. So we know that, for example, some conditions are progress, and we would expect changes, because they are neurodegenerative procedures, and we would expect to see that. But what we also observe sometimes, for example, with DBS, is that the patients will have initial very good response at 1 year. And then in some of the cases, the effect would be slightly reduced over the years. And it's difficult to say if that's because of the effect of the DBS or a progression of the disease at a functional level, even in cases that, in conditions that do not have any structural changes in a functional level, whether this is the cause. I think there is an element of progression of the disease and neuroplasticity, as you mentioned, but not in all subcategories of dystonia.
Okay, brilliant. Thank you so much for your presentation. And I will let you know, lots of people have asked, are we recording this? And yes, they are, but yes, we are, because obviously people will want to see some of your slides and want to actually rehear this several times in terms of the complexity of the research. Great to hear about its application as well clinically. It's fabulous to hear that as well. And so thank you so much, Dr. Tsagkaris.
Thank you very much.
Thank you.
Have a nice afternoon.